5-year-old children. Okay. Penny, Penny, Penny. Okay, have y'all seen the show where, what's her name? Amy Farrah Fowler. Basically thwarts his repetitive things that he does just to show him how much anxious he is with that. It's a very good indication of what kind of anxiety that these people have. One of the things that you will see is that with OCD, okay, remember there is a difference between OCD and OCPD, the Obsessive Compulsive Personality Disorder, okay? OCD, basically, whenever you're looking at that, it is a very disabling anxiety disorder. This person has obsessive thoughts. They will have compulsive repetitive behaviors. And those things tend to dominate that person's life, okay? An obsession basically is a thought that goes around in your head in response to some type of stimulus. A lot of times what you will see is that thought is dirty, dirty, germs, germs, germs. Okay? They're either a nurse or they have OCD. Or they're a nurse with OCD because we scare you to death with all of these diseases that you've got. Okay? One of the first things that you learn when you're up on those units, foam in, foam out. Foam in, foam out. Wash your hands in between. If it's C. diff, don't foam, you wash. So the difference between that as a protective mechanism than an obsession and a compulsion is that there is a reason why we as nurses wash, foam in, foam out, or wash our hands. This person basically, often what you will see is that they have this compulsion, obsession about their germs everywhere. Well, there are, but what you see is that they would have to wash their hands maybe 20 times or whatever their key number might be. Now, for them to have this diagnosis of obsessive compulsive disorder, they have to lose greater than an hour a day carrying through their obsessions to compulsions. Now, for OCD, you can have pure obsessions, you can have pure compulsions, but the majority of these people do have both, okay? As we talked about, the obsessions are those unwanted, intrusive, persistent ideas or thoughts, impulses or images that cause significant anxiety or stress. And this is the key. It causes significant anxiety. Okay, OCD is one of those very, very high anxiety disorders. The compulsion may be that unwanted repetitive behavior, the act of washing their hands, the act of closing the door, the act of whatever it might be. It is to reduce the anxiety, but not to provide pleasure or gratification. So, if this person has these obsessions, these intrusive thoughts, and I prevent them from doing whatever it is to reduce their anxiety, I prevent their compulsion, what's it going to do to their anxiety level? It's going to greatly increase it. Okay? Now, what you will find is that these behaviors exist along a continuum. And what you often see is that The more severe symptoms, that dirtiness, contamination, germs, cleaning and hand washing. Now, if I'm washing my hands 20 times every time I touch an object, what's that going to do to my hands?
Dry them out.
I'm going to have some kind of dermatitis, aren't I not? Okay? I have seen it to the point where they have almost degloved, i.e. removed their skin from that excessive washing. What you often will see is that these people that have the most severe symptoms often have those persistent thoughts of sexuality, violence, illness, or death. If I don't draw 6 cartoons in 15 minutes, I'm going to kill somebody. Okay? If I don't open and close the door, someone's going to break into my house. A lot of times what you see is that violence and death, those are the people, yeah, we all go around at least once a night and checking all the windows and doors. But these people might do it 6 or 8 times at night before they can go to bed. Okay? Now, whenever you're talking about OCD, there is a genetic linkage that's strongly supported. Sometimes they think that there's some type of dysregulation of serotonin. And one of the reasons that they think it is a dysregulation of serotonin is that SSRIs are one of the fairly effective treatments for this disorder. Now, streptococcal infection can be a cause. There is a syndrome called PANDAS. Pediatric, I can't remember what it is off the top of my head because I forgot my notes. But it is a neuropsychiatric disorder that a lot of times these young people, typically teenagers, will have a response to streptococcal infection and will do these movements that are obsessions and compulsions as a result of that streptococcal infection. One of the things that you will see is that with this family history, you know, there may be that problem with serotonin, but typically what happens is there is a major life stressor of some sort that may trigger this. Typically what you will see is that with OCD, young children will have it, and the younger that this person develops this disorder, the more disabling it's likely to be because the prognosis is poor. The need to have things in a certain order, okay? This would bother someone with OCD. And what you would see is they would rearrange this, okay? They put all their M&Ms in colors, okay? I have seen patients that will separate a bag of M&Ms into different bowls by colors. I don't know, as kids we always save the green ones for last because you made wishes on the green ones. It's just like getting a Tootsie Roll Pop with the Indian on it. You know, you can make a wish. But typically what you will see is that this can be very, very disabling for someone that has to do that. Now, what we typically used to think of with OCD is that hoarding was also one of the things that you saw that they felt that it was an obsession and a compulsion to save things. With DSM-5, hoarding sort of has moved away from OCD, though a lot of your textbooks will still talk to you about it as an obsessive compulsive behavior. But hoarding is a problem too. You know, you may have people save newspapers, Howard Hughes saved something like 15 years worth of newspapers. He saved his urine. There was one room in his house that had jars of urine in it. There are some cases where they think animal hoarding is an obsessive compulsive behavior. I'm not talking about the lady with 13 to 20 cats. I'm talking about the lady with 150, 200 cats, okay? Of course, if you don't spay and neuter, then that 13 will become 300 cats very easily. Here with this person, you can see all of the shoes. All right, sort of like Imelda Marcos there. But you can see how lined up that they are. The clothing is right there. This is the bedroom. That's the bed right there in the middle. So where do you think this person sleeps?
On top of clothes.
Who knows? I doubt they sleep on top of the clothes because they're so neat. Now, with hoarding behaviors, excessively, with OCD, basically collecting items, they exhibit a failure to discard those items. Approximately 50% of patients who have hoarding have co-occurring OCD. What you will see is that OCD with hoarding, basically, these people have a very poor response to treatment. Okay? If there's hoarding without OCD, often what you will see is that they, again, have difficulty discarding possessions, but it exhibits extreme stress whenever someone tries to discard an item. Often what you will see is interventions, family members, cleaners, authorities are staged. And typically what you will see is that the authorities will step in, condemn the house, and say you've got so many days to clean it up. Let me just see if I can show you a video that I found. Have any of you watched that show about hoarding? Typically what you will find is that a lot of times it's the health department that comes, or a landlord that comes, that causes them to have some type of intervention. The thing that you will see is that with a lot of these hoarding behaviors, a lot of these obsessive compulsive behaviors, a lot of them will have very poor insight to their behavior. So if they do not have that insight into their behavior, it is less likely that they're going to be able to be treated because they don't follow the program. You clean everything out and they start that hoarding behavior again. Now, what would you do to help that woman with that anxiety that she was experiencing because of them cleaning out her house? Well, it was Prozac maybe, but what else would you do?
Distraction.
You could do distraction, but sit with her. Okay, typically what you'll see on TLC or these hoarding shows is that they will have a psychologist with that person talking to them about their feelings. Because what that hopefully is trying to do is decrease the anxiety and hopefully help them gain some insight into that behavior. If you don't do that, you saw the extreme anxiety and anger that this woman experienced.
Would that be like DBT and CBT?
We'll talk about those types of treatments in just a little bit. But yeah, what she was asking, is it DBT and CBT? Cognitive behavioral therapy is one of the things that they do that works very well sometimes with OCD. Now, one of the things that you want to do is that, we missed some. No, we didn't. All right. Cognitive behavioral therapy is, like she was talking about, was effective in about 80% of the cases. Basically, cognitive behavioral therapy, one of the ways that we do that is to have them to record the frequency, the intensity, and the duration of that obsession. So that what they do, instead of immediately following it with a compulsive behavior, is that they write how they were feeling, how intense that sensation was, how many times that they had that sensation, and if they were able to decrease the compulsion. Okay? You want to rank those obsessive thoughts from the most to the least distressing. Typically what you will see is that sometimes if you give these patients a little bit of a victory by having them to address the least distressing obsessions first, and they're able to stop that compulsive behavior, then they're better able to go to those most distressing thoughts and then prevent that behavior. Okay? Now, one of the other ways that you can do is to expose them to the feared stimulus. Now, this is one of the things that you can't just, anyone, take this person that has OCD with a fear of germs and dirt and plunge their hands into a pile of cow manure. Okay? And that is one of the therapies that they will do. Expose them to a horrible stimulus, what they fear the most, and then help them to overcome that compulsion to wash. But it's not just anybody. A regular staff nurse would not be the one to do that. It would be their psychiatrist or psychologist or a trained therapist. Okay? But those are some of the things that you will see. Now, yoga, basically, again, it is one of the ways to reduce stress. So you want to make sure that you give them some way to reduce that stress. Yoga is a better way to decrease anxiety than following through with a lot of the compulsions that these patients have. Now, when you're talking about drug therapy, nothing new that you guys haven't seen before. What are these typically used for? For depression, okay? What you often see, though, is that doses for these medications will be a little bit more than they are for depression to help overcome those obsessive thoughts and following through with the compulsions. Prozac, Paxil, Zoloft, and Luvox, typically what you'll see, they will be like 1.5 to double the dose that you will see sometimes with depression. Anytime you elevate the dose, what are you going to do with side effects? Increase the side effects. SSRI side effects you have to worry about are what, guys? Suicide, definitely. Weight gain, sexual dysfunction, dry mouth, fatigue, sedation, and restlessness, okay? One of the things that you got to remember about these SSRIs is that if they have been on them for a while, do not abruptly discontinue them. If you do, you will get what we call discontinuation syndrome, and you can have dizziness, headache, diarrhea, insomnia, nausea, and decreased mood. Typically, if they're having side effects, they bring them back down to what a normal level would be, or until the side effects don't show up anymore. If they want to get them off them permanently, which they often will do with OCD, because typically you're not going to be on these for the rest of your life. Hopefully what you're going to do is undergo that cognitive behavioral therapy so that you're better able to deal with that stimulus. So they typically will taper these people off of these meds after about 2 to 3 years. Okay? Now, one of the medications that you'll see that they often will use are the tricyclics, anafranil. It works very well for OCD. What did Ms. Rummel tell you about tricyclic medications? Okay. What else did she tell you? They're older drugs. Cardiac complications often. Am I going to have a doc that's going to write me a script for 90 days on these meds? No. 30 days max. One of the things that you'll see with tricyclics is overdose on tricyclics is probably one of the most deadly antidepressants to overdose on. People will commit suicide with tricyclics much higher rate than any of the other medications. So typically what you'll see is a 30-day supply or less on these meds. That doesn't mean that a 30-day supply won't do it. It just means that they're less likely to do so. Physical exam and assessment interview, one of the things that you have to do is to find out what is causing this trigger, what's causing this anxiety, what is causing these obsessive thoughts. Because if you don't get rid of the source of that anxiety, you are not going to be able to help this patient with OCD. These are some of the nursing diagnoses that you will see. Risk for caregiver role strain. Why? If it's the spouse or if it's a child. You know, what did that guy say? That he was always late for work? You know how hard it is to get your kids ready for school now? What if they had OCD and had to take the 2 showers? Had to try on 2 sets of clothes? Eat 2 separate breakfasts on 6 different plates? Okay? It can be very, very difficult. The thing that you've got to remember is that typically what you don't see up here is either self-directed or other-directed violence. Typically your patients with OCD are not violent. They may have a risk for injury related to that constant hand washing or showering or whatever, but typically these patients are not violent. Unless you saw whenever that woman, though she was not physically violent, she was verbally abusive, okay? So that anxiety building up can lead to that verbal abuse. And caregiver role strain is going to be a problem. So again, identify triggers, a quiet, restful environment. Those of you that were on LifeWorks this past Thursday, we know that quiet, restful environment was not possible. They were moving furniture in and out. And what did we see in those patients up on the unit? They were getting very agitated. They had 3 people on 1-to-1. And not only were the patients that were on the 1-to-1 marching up and down the hall, the sitters were having to march up and down the hall with them. It looked like a parade. The movers were moving furniture in and out. The drills were going because they were putting the tables together. I had a headache. And I can imagine the patients that had schizophrenia up there were having major problems, and we saw that with the agitation. They were trying to get away. That quiet, restful environment helps to decrease some of the stimuli in every patient that you will see. Reassure that client that their continued behaviors are not an indication of failure. We want these patients to have small attainment of goals. It doesn't have to be that they have to quit immediately, because that's probably not possible. What we hope is those SSRIs are helping to decrease those compulsive thoughts, and they're able to then control that compulsion. But what we might want to say is that you decrease the number of times that you wash your hands tomorrow. And then the next day you set a new goal. Small, attainable goals for these folks. Again, we want to be supportive in a non-judgmental demeanor. Because, you know, if I have to take my pills, separate them out by color, separate them again by, these are my blood pressure medications, these are my antidepressants, these are my vitamins, and then I have to take one pill and take 3 sips of water. Okay? You can't leave the bedside until they take all their pills. You're on IP, so you have 4 other patients with another 30 pills to take down the hall. How stressful is that going to be for you, as well as for that patient if you're just standing there? You just take the pills. Okay? Just be aware of that. What we want them to do is to demonstrate adequate coping skills to control their anxiety. And what you hope is that there are some advocates for those patients. This is a nice one, the National Alliance for the Mentally Ill. Basically what we want is for your patients with OCD to have some resources. There are some resources available for the National Alliance for the Mentally Ill. And we want to make sure that they have those resources that they need. All right, let's take a look at this. Patient has been admitted to your psychiatric unit after being found by a friend in his apartment. The patient has not left the apartment for 2 weeks. You're completing the admission assessment and search his small brown suitcase. You notice that the patient, using black ink and precise lettering, has etched his first name, Clem, on the side. The suitcase contains 3 t-shirts, 3 pajama bottoms, and a toothbrush wrapped in several layers of plastic. You return the suitcase to him. He begins to unfold and refold his clothing very slowly and repetitively. What's your best nursing action? Do we stop him?
No.
Be non-judgmental to just
Allow him to basically continue folding and refolding until he gets okay, because what we don't want to do is to stop that behavior without substituting something else in that place, either the cognitive behavioral therapy or medication to help him control those obsessive thoughts. Okay, questions about OCD? All right, so let's take another break. Be back at about 20 after, and we will start with...
So you stop it, and when I stop it,